I'd like to welcome you to this ESOU webinar, where we're going to discuss an important topic in prostate cancer, and that is the status and challenges in the management of castrate-resistant disease. And we've got two real experts with us this evening who are going to give us an overview. We have Stephen Joniau from Leuven in Belgium, who's going to talk about the status and challenges in the management of castrate-resistant prostate cancer, or CRPC. And we've got Frederica Schlürmann, who's an oncologist from Brest in France, who's going to talk to us about a really hot topic in this area, personalized medicine and molecular testing, and who is the right candidate. There are going to be two talks. They'll be about 20 minutes each, and then we'll have a session where we'll address questions, and we'd be very grateful if you would send your questions into the chat box. We'll try and answer them as they come in. I'm sure we'll generate a number of questions throughout the talk. So we're going to start with Stephen, who has agreed to talk to us about the status and challenges in the management of CRPC. And it's important to recognize that Stephen's a urologist, and this is not just an oncological, non-surgical disease. This is a urological disease. Stephen.
All right. Thank you very much, Neil. I'm going to share my screen. I hope you see it. So, as you said, the current status, and also challenges we still face in the management of CRPC, that's what I'm going to deal with. These are my conflicts of interest. Recognize quite some companies which are involved in the management, drug development in CRPC. Now, just recapitulating, what is CRPC? We all know, and I was lucky enough to just start right before this whole evolution in the treatment of CRPC disease started. And in the first days when I was a urologist, this is exactly what we did. Patients presented with metastatic disease, and we castrated those patients, either surgically or with LHRH analogs or antagonists. And what happens if you do that is that you block testosterone production in the testis. And by doing that, circulating testosterone will lower by 95%. It will never be zero. And by doing so, the tumor stops growing and you'll have a happy patient for a while. So initially, ADT prevents tumor progression, but after a while, this tumor started to grow again. And I remember, I'm not that old, but old enough, we thought, okay, now we have a tumor which is hormone refractory. We called these tumors, hormone insensitive tumors. And then we fiddled around a little bit with anti-androgens or changed the LHRH treatments or add something else, high dose glucocorticoids, whatever, but nothing really worked, and those men died in terrible pain. What we did not realize at that time point is that these tumors are not resistant to hormonal treatment. They have become addicted to the least possible concentration of testosterone or whatever looks like an androgen. We didn't know that in those days. And what I did see appear in 2004 is at last a treatment which could help patients. And that treatment was docetaxel. Docetaxel is chemotherapy. It's a taxane. And it acts by disrupting the microtubular network in prostate cancer cells, stops cells from dividing, cells going to cell cycle arrest, going to apoptosis. Also, there's blocking or inhibition of BCL2, which is a molecule which is important for cancer survival. So finally, we had something in 2004 which could expand life a little bit, just about 3 months in patients who are not anymore responding to hormonal treatment. But what we did soon after started to realize is what I just said. That is that patients with metastatic CRPC, they are not insensitive to hormonal treatments, actually the androgen receptor remains a driver of the disease. And here you see specific mechanisms how the androgen receptor still is driving the disease. At the one hand, sometimes, and it was shown that prostate cancer cells were expressing enzymes which could actually induce testosterone production within prostate cancer tumors. So these tumors were producing small amounts of testosterone themselves, keeping the cancer growing. Even though you couldn't measure this testosterone in the bloodstream, there was local testosterone production. Second, most of these CRPC cancer cells, they overexpress the androgen receptor, and because there are so many androgen receptors, any androgen passing by will activate these cells to grow. We also detected splice variants, and splice variants, some of those don't even need testosterone anymore. They're active on their own, and they stimulate cells to grow. Androgen receptor mutants, and also parasitic pathways, which are also activated and which are also interplaying with the androgen receptor. So the androgen receptor, we realized after a while that the androgen receptor can still be targeted, and the androgen receptor targeted pathways can still be targeted by treatments. And one of those treatments is abiraterone, and abiraterone is a CYP17 blocking agent. What does that mean? It blocks the production of testosterone from the building block cholesterol by blocking two specific enzymes. And by doing so, it reduces levels of DHEA, androstenedione, estradiol, and testosterone. And you can actually call abiraterone a sort of super castration. It blocks testosterone production wherever it is produced. Other targeted agents targeting the androgen receptor itself are enzalutamide, apalutamide, darolutamide, and they directly target the androgen receptor, and they inhibit testosterone to bind to the androgen receptor. They inhibit also or prevent nuclear translocation, and also impair the androgen receptor from binding to the DNA and initiating gene expression. So now we have docetaxel, and we have specific hormonal treatments, abiraterone and enzalutamide, because apadarolutamide were non-existent in the beginning, to target the androgen receptor and also to treat cancer cells with chemotherapy. And that is exactly what happened. So 2004, we saw docetaxel appearing, and later on we had Cabazi, which is also chemotherapy, second line. It's also a taxane, and then Abi and Enza, and that is the drugs we played with. Radium-223 also appeared a little bit later, and radium is an alpha-emitting agent. Radium is in a table of Mendeleev in the same column as calcium, so it's built into the skeleton at the places where there is an overturn of bone metabolism, and it irradiates with alpha irradiation locally tumor cells in the tumor environment. And it's only later that olaparib and rucaparib and the BART molecules are not available in Europe. Olaparib is a PARP inhibitor, more about this later, and also very recently lutetium PSMA came on the market. But we're going to talk about those two mainly in the further presentations. So what did we have for a long time? First line CRPC treatment. We had to choose between abiraterone, enzalutamide, docetaxel. Those were the drugs to play with in the first line mCRPC patients. They only had been treated with ADT. They were castration refractory, and those were the drugs to play with. And as usual, Abi and Enza were first tested post-docetaxel, then were moved earlier to first-line treatment. But in the meantime, since we've seen all this evolution of treatments in CRPC, these drugs also moved further down the timeline to hormone-sensitive prostate cancer, non-metastatic prostate cancer, even moved into localized high-risk disease. So these drugs have been moving to the left side of the spectrum in the meantime, and in the same time, other drugs have appeared on the market. So it became a little bit complex, to make decisions. The second problem was if patients were again resistant to first-line treatment when they had mCRPC, then we had to make different and other choices again. And here you see a schematic impression or scheme flow chart, if you want, on how we do that. If patients progress on a first-line treatment, which is Abienza or docetaxel, we have to base further treatment decisions on performance status, comorbidities, extent of disease, genomic profile. We're going to talk about this well, patient preference, prior therapies. And one golden rule is we have to avoid sequencing AR-targeted agents. Don't give enzalutamide after Abi or Abi after Enza, but switch to something else. And here you have some examples on how you make decisions. If patients had prior chemotherapy, 1 or 2 lines, and switch to ARTA, to androgen receptor targeted agents. The other way around, if they had Abi or Enza first, if they had Abi Enza plus docetaxel and they did not respond long, they only responded less than 12 months to an ARTA, switch to cabazitaxel after docetaxel. Don't switch from Enza to Abi after docetaxel, or don't switch from Abi to Enza. And you can also consider now using these novel agents, PARP inhibitors or lutetium PSMA. And that is something we're going to talk about further during this talk. Because in 2015, and this is just one paper, but I think it's a very important paper, this paper here from Robinson described in-depth molecular analysis of tissues from metastatic lesions of patients who had mCRPC. And they did a very, very thorough analysis, molecular analysis of those patients. They sequenced RNA, DNA, and so forth. And what they saw is that a lot of these patients, about 80% of these patients, had molecular pathways which were clinically targetable. So they had clinically actionable molecular alterations, such as CDK4, CDK6, and there are CDK4/6 inhibitors, DNA damage repair genes for defects in many of those patients, BRCA1, BRCA2, ATM, and so forth. PARP inhibition would be exploited, or platinum-based chemo, PI3K pathway aberrations for which PI3K or ACT inhibitors can be employed. And that was very, very important. Those insights really make things move forwards. Look at the tumor, look at molecular signatures, and then move your treatment forward. And that is exactly what was done. So here you see from the same paper that 22.7, almost 1 in 4 of the patients harbored alterations in DNA repair genes. BRCA2, most of the patients who had alterations had BRCA2 or ATM alterations, and some had other DNA repair genes which were altered. And about 1 in 5 had aberrations in the most frequent BRCA1, 2, and ATM, conferring a possible sensitivity to PARP inhibition. That was already in the paper before we were using PARP inhibitors in clinical practice. How do these PARP inhibitors work? Well, if there is a single strand break, which and often DNA is attacked by anything, oxygen, by peroxide, by UV light, name it. Single strand breaks, they are detected by PARP, and PARP is just sitting there and is accruing the whole mechanism to repair the DNA. Imagine a patient in whom you don't give PARP inhibitors, and who, this patient will be able to repair DNA. If you give a PARP inhibitor, PARP will be stuck on the DNA. And if the PARP is stuck on DNA, the replication fork will stop there, and there will be a double strand break originating at the same place. So all of a sudden, if you give PARP inhibition, you on purpose induce double strand breaks in the DNA. These double strand breaks usually can be repaired by BRCA2, BRCA1, ATM, by whole repair, which we call homologous recombination repair. And these genes in homologous recombination, most importantly is BRCA1, BRCA2, they're able to repair double strand breaks. But if you're lacking BRCA, because you have a BRCA mutated germline or somatic default or defect in the tumor, you will not be able to repair double strand breaks, and these cells eventually go into programmed cell death. So patients with BRCA mutations, if you give PARP inhibitors, you will induce double strand breaks on purpose, because you know these patients cannot repair double strand breaks, and those cells will go in programmed cell death. So you induce synthetic lethality for prostate cancer cells in those patients. And the first study that showed that this works is the TOPARP-B trial. This was an open label trial. It studied olaparib in 2 doses in mCRPC patients, 300, 400 milligrams. And here you see the PSA response, the RECIST response of patients with several different homologous recombination repair, HRR alterations. And you can see that those with BRCA1 or 2 had the best responses. PALB2 also had good responses. Some patients with ATM had good responses, and others were not always responding very well. That is interesting, because that led to inducing and initiating the PROfound trial. And the PROfound trial was a trial in mCRPC patients who progressed on prior new hormonal agents, for instance, ABI or ENZA. And they could also have had chemotherapy, but it was not mandatory. And they needed to have alterations in at least one of any HRR genes. And then they were separated in 2 cohorts. Cohort A, based upon the TOPARP-B trial, BRCA1, BRCA2, ATM, because they were the genes in which you would expect the best response when giving olaparib, and cohort B, which were all the other alterations, and they were randomized to olaparib or physician's choice of treatment. They're all CRPC patients resistant to at least a first line of ABI or ENZA. These were the most common gene alterations, BRCA1 and 2 in cohort A, and ATM as a second. Some patients had both. And then cohort B, there was mostly CDK12 and other smaller groups of other HRR gene mutations. What the conclusion was that olaparib only seemed to have a clinical effect in cohort A, most importantly in cohort A. Radiographic progression-free survival was the primary endpoint, and you can see here the very dramatic and very important differences in imaging-based progression-free survival between olaparib or standard of care. And in the BRCA1/2 subgroup, this difference was even more pronounced. So this shows here that in a phase 3 trial, indeed, PARP inhibition works in a CRPC setting. Even overall survival in cohort A, BRCA1, BRCA2, ATM, was improved and was significantly improved with a hazard ratio of 0.69. So these trials showed that all of a sudden, after chemotherapy and after ENZA, abiraterone, there are other treatment modalities which work. But remember, this trial here, the PROfound trial, was a monotherapy use of PARP inhibition, not combined use. What else can we do? Well, I've just said to you, if you do molecular analysis, you find HRR mutations in BRCA1, BRCA2, perhaps also ATM. You have a target. You know you have a target, and you target it with a targeted treatment, PARP inhibition. What else do we have as a target? We have PSMA. Everybody knows PSMA because we're all doing PSMA PET CTs in all kind of clinical situations, mostly recurrent patients after local treatment, or sometimes also for primary staging. Well, we use then a positron emitter like gallium or fluorides attached with a linker to a vector, and the vector is finding PSMA inside the body, and it gives you fantastic and nice images, much better than bone scan and CT or MRI. But what you can also do is change the radionuclide, the positron emitter, to an alpha or beta emitter, like lutetium or actinium. By doing so, first, you do imaging. You know that you have a target. You know where the target sits. Second, afterwards, you give a drug which targets exactly the same lesions and uses alpha or beta irradiation to treat the tumor locally. And this treatment here was first tested in Germany and developed in Germany, really. And these are just smaller trials, really showing very encouraging results with PSA decreases of more than 50% in about half of the patients, and any PSA decrease in 3 out of 4 patients. But survival outcomes were very sparse and were not really the first goal of these trials. And the first trial, which looked at outcomes, other oncological endpoints, was the therapy trial, published in 2021, as you see, by Michael Hoffman. It was performed in Australia. mCRPC patients were included, and they all had to have failed first-line chemotherapy, and they all had to be, at the time of inclusion, considered for cabazitaxel. Why? Because the patients were randomized to cabazitaxel versus lutetium PSMA. They also needed to have gallium uptake in all known metastatic lesions, and because they received both an FDG and a gallium PSMA scan, PET scan, and they should not have a non-overlapping FDG positive but gallium PSMA negative lesions. And also this SUV max of the largest lesion needed to be more than 20. And the first endpoint was a drop of PSA of at least 50%. And here you can see the cabazitaxel and the lutetium arms. And you can see a fantastic and much more important drop in PSA in the lutetium PSMA versus the cabazitaxel arms. Even overall survival was improved when the results were first published, and grade 3 to 4 adverse events occurred to a lesser extent in lutetium versus the cabazitaxel groups. You would say, wow, there we have a new treatment, a second-line treatment after docetaxel. Now we choose lutetium PSMA instead of cabazitaxel, at least when patients have a PET scan and an FDG PET CT, a PSMA and FDG PET scan, which are nicely overlapping. But it was a phase 2 trial, and with a phase 2 trial, you cannot change practice. So we needed a phase 3 trial, and the VISION trial, published also recently, was a large phase 3 trial. All patients needed to have failed at least one taxane regimen and at least one androgen receptor targeted agent regimen. All the known sites of disease should be positive on gallium PSMA PET CT, and they were randomized to lutetium versus standard of care. And there's maybe a little weak point there, is that standard of care was protocol permitted standard of care. That was treatment excluding another line of chemo, excluding immuno or radium or any other investigational drug. And that was a little bit different if you compare it with the therapy trial, because there an active treatment, a standard active treatment, was compared with lutetium. Nevertheless, the overall survival and radiographic progression-free survivals were both significant and very impressively significantly positive. And the side effects of lutetium versus standard of care were a bit higher in lutetium PSMA versus standard of care alone, but the difference was not very, very impressive, I would say. So now, okay, I told you in the beginning that all the treatments we tested in mCRPC, second line, first line, second line, third line, are moving towards first line treatment and even earlier in the disease stages. And these are the trials now which have been performed with PARP inhibition as first line treatment in mCRPC. And Frédéric is going to explain these trials to you. One big difference here is that in these trials, the PARP inhibitors were combined with ABI or ENZA, right? They were not monotherapy treatments. They were combined with an already known active treatment in the setting where the PARP inhibition was studied in first line, okay? And they were compared with ABI or with enzalutamide versus the combination. Why, or what is the rationale of combining an androgen receptor targeted agent and a PARP inhibitor? Well, if you inhibit PARP, PARP also controls androgen receptor function. And so a PARP inhibitor additionally sensitizes the anti-hormonal treatment. So PARP helps androgen receptor blockage, and androgen receptor blockage causes a deficiency of HRR genes. Why? Because HRR genes are within the transcriptome of the androgen receptor. And so androgen receptors create some sort of a BRCA-ness, a situation as if cells are deficient for BRCA. So these two treatments, they help each other. And so there is a rationale or a basis of combining those two treatments in CRPC. And yes, well, what you're going to hear is how these drugs have been tested as a combination with an ARTA versus an ARTA alone. The problem now is, and I said it already twice, every drug is now moving towards the hormone-sensitive setting. So now the guidelines say, do not anymore offer only ADT monotherapy for hormone-sensitive metastatic disease. You need to combine ADT with, already combine it with ABI or APA or enzalutamide, or maybe use in low-volume disease radiation to the prostate, to the primary, or perhaps even give triple therapy as first-line treatment in hormone-sensitive disease. We're not anymore talking about hormone or about castration-refractory disease. So if those patients now progress to a castration-resistant phase, we need to redefine castration-refractory disease, I think. And all of a sudden, we need to rethink what I just said. We need to perhaps rethink the role of PARP inhibitors and of PSMA lutetium. But luckily or not, what really happens in clinical practice is since 2015 up until recently is that we are in HSPC, hormone-sensitive prostate cancer. We have been using abiraterone, but less and less and less. We started to use new hormonal treatments, apalutamide, enzalutamide, in an increasing extent, and we have not been using a lot of docetaxel for first-line treatment in MHSPC. And what we are still doing is something that the guidelines tell us not to do. Many patients still receive ADT alone when they present with metastatic hormone-sensitive prostate cancer. So there is still a big group of patients, in my opinion, for many years, who will benefit from combining ADT plus new hormonal treatment plus PARP inhibition. I'm going to give the word back to Noel. I hope this was a good introduction to Frédéric's talk.
Stephen, that was a terrific overview and a great illustration, really, of how the landscape has changed so dramatically from the time when Stephen and I guess, were growing up as urologists, which seems a little time ago now. But anyway, here we are.
Yeah.
So we're going to move on to the hot topic, which Frederica is going to talk to us about, which has had an airing and an introduction from Stephen, as you got. The flavour of the time in CRPC is combination therapy, and particularly combination with PARP and other treatments. So Frederica, perhaps you could take us through this issue of genetic testing. Who gets the drugs? What do we do?
Yeah, thank you, Noel, and thank you, Stephen, for the introduction. I will open my slides. I hope you can see them. Sorry. Up. So I hope you can see my slides. So yeah, we had a great introduction on new treatment option that we have now about personalized medicine. So my activities, my interests. So I'll talk a little bit about personalized medicine, prostate cancer, the myth or reality. Where are we right now? Do we have already some personalized medicines? And I think we do. Stephen talked about some of them. And then the molecular testing in practice, like why, who, when, and how. And I will explain a little bit how I think we should maybe implement that now, seeing the results of the studies that I will present to you, obviously, like how we propose to do that. So I think we already have some personalized medicine in prostate cancer. We have molecules targeted the AR signaling. We will use to that, androgen deprivation. We have targeting bone microenvironment agents. We have PSMA, and we have targeting cell cycle treatments, which is now under in clinical trials right now. And we have a couple of other options that I will talk about real briefly. So we have things. So if you see the current status, it's not exhaustive, but is that what we have? We have, like I said, bone targeting therapy. We have some immune therapy in some countries, the endocrine therapies that we have, like ABI, ENZA, all the other NHAs or RSAs that we call them too, and the therapeutic radiopharmaceutical. So we're not that bad. I think we already have some more treatment options that we had years ago. So it's getting better for sure. But there's still, like Stephen said, like room for improvement, because we know that we lose about 50% of the patients every time there's a progression from line to line. That's what the numbers tell us. And like he said, Stephen, we still not do as good as we should in first line and mCRPC setting, because we see that only 30% of the patients are intensified in the first place within NHA, which is still kind of shocking for me. Unfortunately, we have about the same numbers in France, and it's even might be a little bit worse. So we really have to work on that. So the trials in progress, real quick, like I said, we have targeted therapies in progress right now. We have a couple of trials going on with targeting the cell cycle with CDK4 and 6 inhibitors, the palbociclib, ribociclib, abemaciclib. We have those running right now. We have some trials running actually with targeting the PI3K-ATM-TOR signaling pathways, with capivasertib, for example, with docetaxel. So we know that there's an activity, because the first trials, the phase 1 trial, showed that there's a greater than 50% of reduction in PSA levels in 70% of men with mCRPC, and those were heavily pre-treated patients. So that's a good news. And then, yeah, we have obviously the big field of PARP inhibition right now with the niraparib, olaparib, talazoparib, rucaparib. We have like so many options that are like getting like more and more data on it. So I will try to like explain a little bit to you the landscape where we are right now. And when we see this kind of busy slide that we see pretty often, you can see they have a lot of trials. And Stephen, you already talked a little bit about Profound, which was the first trial that showed that there was a big, great activity in mCRPC, giving olaparib alone in patients with BRCA1, BRCA2 mutations. And then you have all the other trials in third line to second line and first line, and moving on to mHSPC trials that have been fully recruited. TELEPO-3 and Amplitude are fully recruited. So we kind of wait now for the data on that. So everything is moving like typically in prostate cancer and other tumor types too, and it's getting earlier and earlier. So PROfound, I won't like talk about that real long because Stephen, you did that first trial who showed the efficacy of PARP inhibition with olaparib, 19.1 month versus 14.7 in patients that were pre-treated, that already have had NHA at least, and some even had chemotherapy. So those are results are kind of great for our patient, great news. So we know that there's activity, but then we move forward to the doublets. And as we heard before, there is a rationale to do PARP inhibition plus NHA. It's not just a random choice to do that. We have the PARP inhibition that is reported to increase the activity of the NHA via the androgen receptor. And then on the other side, you have this proof now that we had in preclinical models in phase 1 and phase 2 trials that the NHA induced HRR deficiency. It kind of creates a BRCA-like environment so that the PARP inhibition works even more. So you have that combined effect. That's why the studies that we have today were done like they were done. So there's a real rationale to do that. So I will go back now to the main trials that we have. We have three main trials. We have first the PROPEL trial, which was a phase 3 study for patients in first-line treatment mCRPC. Docetaxel was allowed, no prior ABI. And patients were all included. It was an all-comer study. There was a pre-specified analysis of tumor tissue and ctDNA to look for RHA mutations, but it was not like other trials. It was not it's an all-comer study, so we didn't have two different study types. So it's two different groups. So patients got olaparib and abiraterone or abiraterone alone, and then we looked at primary endpoints and rPFS by investigator assessment. And overall survival was a key secondary endpoint. And then we have all the additional endpoints that we often have: time to first subsequent therapy, second progression, objective response rate, PSA levels, and so on. So keep in mind, it's an all-comer study. HRR was tested, pre-specified at randomization, but was not known to patients or the clinician who included the patient. So we had data that we showed in 2022 in the New England Journal of Evidence, where we see that in the primary rPFS results, we had an activity for the ITT population, so for all patients, regardless if they had a mutation or not. So we had kind of great rPFS an investigator assessment and with independent central review with a p-value that was impressive. And you can see you have 8 months difference between the doublets and the monotherapy with abiraterone, and that's in the ITT population. So great data on that side. And when you look at the subgroups, because this is something that everybody wanted to know, because everybody was thinking that maybe it's really the BRCA1, BRCA2, or the HRR mutated patients who are kind of like making this those numbers that great. So you can see that even patients who are non-HRR mutated and even patients non-BRCA mutated have a benefit of that combo in the rPFS. You can see that. Obviously, it's BRCA1 and BRCA2 patients who derive the greatest benefit. That was something that we were expecting. But still, all the others have a benefit. All patients, no matter if it's bone or visceral metastasis, no matter if they have docetaxel before or not. That was kind of a great news for us, kind of surprised, but that was what we were hoping for. So the OS final analysis was presented by Noel and ASCO 2023, and unfortunately, it was not significant. It close to it, but it was not. We had a 47.9% of maturity, so kind of early maybe to evaluate it, but well, it was the final analysis. So OS was not significant, but we were close to that, and we still have a difference, 34.7 months versus 42.1 for the doublet. So I think this is kind of impressive. And the thing which is really impressive is to see that we have a median OS at 42 months for patients in mCRPC. This is not a number that we have never seen before in that setting, in mCRPC, and I think we really have to stress that out. Really important data. So after PROPEL, that was presented last year at ASCO GU 2022, we had a lot of discussions about those data, if it's real data or it's just a statistical luck kind of, or is there really something happening for those patients that have no mutations? So we were all waiting eagerly for TALAPRO-2. So TALAPRO-2 was partially presented this year at ASCO GU 23, and we just had an update on the mutated patients at ASCO, and I will just show you the new data too. So TALAPRO-2 was slightly different, but it's randomized phase 3 trial too. Patients were all tested for ARCHA mutations, obviously. Prior Abi and docetaxel were allowed. And you had kind of two cohorts. The cohort 1, you see it in blue, it's a non-deficient or unknown, and the ARCHA mutated. And then you have the ARCHA only cohort, it's the cohort 2. And the blue cohort, the cohort 1, was presented at ASCO GU 23, and cohort 2 was presented now at ASCO. So patients were randomized in talazoparib plus enzalutamide or enzalutamide alone, and you have kind of the same endpoints that PROPEL had too. So we saw the first data, so at ASCO GU 23, the primary endpoint was rPFS for all comers, and you see again that we have great data on efficacy of this combo, with at that time the median that was not reached for the combo, and we have median follow-up around about 24 months, so it was pretty early. So we saw that there's a big signal for all comers, again, confirming what we already saw in PROPEL. So that was kind of great news for us, I think, and for patients, because we still have patients where we don't, we cannot see or find the mutation because we don't have any tissue. I will talk about this a little bit later. So we have kind of challenges for that. So great news for patients again. And so even the subgroup analysis, you see the same thing as in PROPEL. Everybody has a benefit in rPFS. Patients who are not mutated have a benefit too of that combo. So this really shows that there's a rationale of doing a combination of those two treatments. So I just added that slide really quickly because it was presented 2 days ago at ASCO. We had the HRI deficient cohort that was presented, so you can see that there again is a great benefit for patients who have a HRA deficiency. It's not reached yet, the median rPFS. The p-value is impressive. So again, for those mutated patients, we have the great signal that it's really an option for those patients to treat them with the doublet. Then we have the third study, which is slightly different, and it's really important to know that it's different to kind of think about why it is different. We have the Magnitude trial, phase 3 trial, that was presented ASCO GU 2022. Patients were treated with niraparib and abiraterone, but it was 2 different cohorts that were really split up. You had the cohort alteration positive, and then the cohort with all comers kind of a cohort, and that cohort was added to the study when the first studies came out, who showed a benefit for even patients without any mutations. So they kind of like opened that small cohort to see if there's something happened for patients who don't have any mutation, and the analysis was done really soon at 16 months, and it was apparently not good enough, so it was stopped for futility. And so Magnitude only kept on going with the cohorts with the mutated patients. So we don't have not a lot of data from the non-mutation cohort because it would stop at 16 months. So the only data that we have is on mutated patients. So you can see the futility analysis that I was talking about. You can see there was no activity, but again, it was really really soon, 16 months. So they stopped that cohort with a negative signal, unfortunately. And they went on with the BRCA1, BRCA2 cohort and the R2A plus cohort. And then you see that you have an impressive risk reduction of 47% for BRCA1, BRCA2 patients. Those are really the patients who derive the greatest benefit. And you have still a 27% risk reduction for the HRA plus cohort. So again, a study who shows that there's efficacy for those patients. So you can see for the HRA plus cohort, the subgroup analysis, and you can see that everybody derives benefit, no matter where the lesions are, no matter the baseline PSA levels. You still have a benefit when another NHA is giving before, a little bit less though, but you still have some. So we have those three big studies, Propel, Magnitude, and TelePro. Again, sorry, really busy slide, but I know we don't have the right to compare them, but like Propel and TelePro kind of like are a little bit resembling, and Magnitude a little bit different, but still we have three studies who show an impressive benefit for patients with HRA plus tumors, like mostly BRCA1, BRCA2, and tumors that have a benefit from that combo. And then we have TelePro2 and Propel who show in RPFS that there's the benefit too for patients who do not have an HRR deficiency. So what do we do with all of that today? So we have different approvals, and I think it's really difficult because sometimes you have a new approval coming out of EMA and then you have FDA. And so we just have the EMA approval for all comers right now for olaparib and abiraterone. The FDA approved olaparib and abiraterone only for HRA plus patients, BRCA1, BRCA2. This is new. This happened last week, Thursday, Friday. Really hot news. And the FDA and EMA approved for HRA plus patients, niraparib and abiraterone. So we have different labels right now. We can do the combo even for patients without any mutations, and in the US it's more for mutated patients. So that's where we are right now, and we know we have new molecules coming. Like I said, amimaciclib, capivasertib, and other ones, and mCRPC. So the landscape is going to change again. And in MHSP, we have other trials too. We're going to move up PARP inhibition in an earlier setting. So the question is, why do we have to test? And I think we have to talk about that when we have studies where even patients without any mutations have a benefit. We have to talk about that because I think the message of those two trials, TelePro2 and Propel, is not to not test. It's you really have to keep testing. Why? Because it's prognostic. Patients that have BRCA1, BRCA2 mutations are doing less good. They're really kind of the losers, unfortunately, of prostate cancer. You can see it on the right picture that patients are really doing less better on a prognostic level. And we just had this great talk from David Olmos at ASCO 23, who did a great work of so many patients, 729 patients that were included in first-line mCRPC clinical trials. He was looking at the mutation rates that we have, and then he was looking at the outcome of those subgroups. And you can see on the right-hand side that patients with BRCA really do less good than the other ones. Patients without any mutations doing so much better. So you really want to know if your patient has a mutation or not. And it's getting more and more interesting, I think, even when we are going to go and move up the lines, even in localized prostate cancer, maybe you will change the way how you're going to do surveillance when your patient has a mutation. So I think you really have to go on to do that because it's prognostic. And then it's theranostic too for some trials, like we saw in Magnitude. It's important. It's even important for P10 loss for other molecules like that we have to do it. So question is, how do we do it? For who do we do it? And then it's the germline versus somatic tumor testing question. So just to explain really briefly, we have the germline where the BRCA mutation is inherited from your parent. So all cells have the mutation in it. And then you have the somatic side, which is non-inherited BRCA1 mutation. And then you just have it on the tumors. So all cells have two normal copies of BRCA1 gene. And when you have a somatic mutation cell, that can cause more like BRCA loss. So cancer can be associated with this somatic BRCA mutations. So what's the prevalence of those mutations? This is a big question that we have, and we saw this is PROPEL data and PROFOUND data that we have it right now. You can see that we have round about 8% of BRCA2 only mutations and round about 2% of BRCA1 mutation, and then we have other ones like ATM, CDK12, but less. So we focus mainly on BRCA2 and BRCA1 because that's what we see in all the studies. And when you look at all the other studies that we have on PARP inhibition, it's kind of like the same, around about 10% BRCA in general. So that's what you kind of keep in mind. So where are we on guidelines today? How do we test? Who do we test? So the NCC guidelines are kind of like broad. They recommend the germline testing. It's a somatic tumor testing for HRR mutation for all patients with metastatic prostate cancer, and you even can consider it with localized regional prostate cancer. The ESMO guidelines are a little bit different. It's a somatic tumor testing for HRR mutations and for germline testing for BRCA2 to be considered mCRPC mostly when the patient is candidate for PARP inhibition, or if you have family history, that kind of like evokes you that there might be a problem on the BRCA1, BRCA2 side. And the ESOU guidelines suggest somatic tumor testing and or germline testing in patients with mCRPC, really broad guidelines. So how do we do it? Because this is really important now that we are talking about this subject so much about PARP inhibition. So I try to do this clinical pathway of testing because we have to organize ourselves, because we won't do it on our own as an oncologist. We have to work together with the urologist, the pathologist, molecular biology. We have to really talk together with the oncogenetic council. So it's really a multidisciplinary organization that you kind of have to implement in your own clinical practice. So once you decide that you want to do a somatic tumor testing, if a patient is mCRPC or for a clinical trial, then you should try to do it on the freshest tissue that you have. Ideal would be under 10 years, but we know even 5-year tissue is pretty old and you risk to not have any results with that. So if you don't have fresh tissue or not that old tissue, you can try to biopsy metastasis other than bone if it's possible. Bone is really a tricky thing for the pathologist. And if you are not able to do that either, because often we have patients with bone-only disease, so this is kind of challenging, then you can ctDNA. In some centers, you can do that. And I hope it's really getting forward a little bit faster with ctDNA because it's really convenient. And I think in prostate cancer would help us so much. So I hope we're going to speed that testing up a little bit. So once you have that, then you send it to the pathologist and he's going to do the DNA extraction. And then you do molecular biology of the testing. And if you fail, then you have to try it over again and see if you can do another biopsy to get your results. And if you have a test result and you have a mutation, then you can treat your patients depending on the label that you have in your country. And you should really consider to send your patient to the oncogenetic constellation for germline testing to see if there's a family history, maybe of BRCA1, BRCA2 mutations or other mutations. So this is kind of my suggestion of how you can organize yourself to do that testing. But it is a challenge. You have to organize yourself, and it's not easy, but I think we can get there. So thank you very much for listening, and I will just be happy to answer your questions, and I will get back to Noel.
Thank you, Frederica. And again, a terrific and bang up-to-date view, which illustrates just how quickly the field is moving. And the title of this ESOU webinar is Status and Challenges. And I think you've seen what the status is. You get a feel now for the kind of challenges that we run with. Now, we've got about 10 minutes to go, and we've had a few questions coming in, which we've tried to answer on the chat. I'm going to ask a couple of questions. Really, I'll start, Frederica, with you. Gene testing and tissue, it's hard work, isn't it? So with tissue, there's about a 60% positivity, even on fresh tissue, for various reasons. Where are we with circulating DNA? A blood test that will pick up the tumor DNA and tell us what we need to know.
I think the key is that we probably have to test earlier and earlier to get fresher tissue. I think now we should really discuss to test patients in the mHSPC setting right away to not wait for the test, for the tissue to get too old, to have it right away right up front. ctDNA is really convenient because it's just a blood sample. It's convenient for the patient, but it's still not really implemented in all centers. I can do it on my own, really only in the clinical study. So I cannot do it. So as you said, it's really a challenge, but test early. I think you don't wait for your patient to get on the mCRPC setting and wait the tissue to get older and older. Do it up front. That would be helpful, I think.
There's a question come in from one of our listeners. Can you prescribe PARP inhibitors without oncogenic testing? Now, Stephen, I'm going to come to you because in the urology clinic in Leuven, a big centre in Belgium, you may have genetic testing, but I'm aware that around the patch, it's just not available to various people. So what's your view of this?
It would be fantastic. In Belgium, we can't. So to be very clear, we cannot prescribe olaparib, for instance, and then do the testing later on. So we have to do the testing first. And I fully agree with Friederike that, and that's also what we try to implement, but it takes a little bit of time, is to use as fresh as possible tissue. Don't wait until the patient is 5 years down the line, because then you'll have a lot of patients in whom you miss the opportunity, or you have to go with a biopsy needle, try to biopsy metastatic lesions. But imagine that you could, and I think in Germany it's possible, and maybe in other countries as well, you could prescribe it without germline testing or without testing. Somatic testing, as you said, Friederike, is the most convenient. Then what I would do is I would start the treatment and I would do the testing in the meantime. And if the test come back negative, I may de-escalate. I may consider that, depending on side effects of patients, depending on perhaps a first scan you do, results you see come back, because you know that in the bracket or in HRR negatives, BRCA negatives, mainly, it will not have the best possible effect. And so that is, to me, the way to go. And I look at you, Friederike, perhaps in France, and you know, perhaps this is possible. I don't know.
Yeah, in France, we can prescribe. We have an early access program for Propel, so
Okay.
we can prescribe it in early access. So for all comers, we can do that. But you're so right. I think the great message of TALAPRO-2 and Propel is that you can, like you said, give the possibility to the patient to start up front the combo, and then do the testing, and then don't lose that time for testing, and just like start the treatment. Because after all, we have had a lot of discussions about tolerability, about side effects. And I think after all, as an oncologist and urologist, it's manageable. It's really manageable. So I think you can start the combo right away. You just have to survey your patients, obviously, see for anemia, fatigue, and everything. But you don't take a big risk in starting the treatment and then do your workup and try to find the mutation afterwards. I think that's really the good news about the EMA label that we have. Unfortunately, for once, we're better in Europe than the Americans are. We can do that. Unfortunately, we can do. And it's a little bit, I think it's a little bit sad that you cannot do that in the US right now, but well, that's like it is.
Yeah, I think the important message really from Propel, and to an extent from TALAPRO, which is quite reassuring as backup, is that it does work for a variety of patients, not necessarily with HRR mutations as well, and certainly not completely for BRCA mutations. So in the absence of any gene testing, and if it's reimbursed, I would give the combination, actually. The toxicity is acceptable. Now, we've not got much time, just a couple of minutes, and I just want to backtrack a little bit, because an important thing was raised in your talk, Stephen, and that is this question of dual and triple therapy. Now, one of the questions that came in was that a lot of patients are pretty old and frail. We had pretty good data from England and Wales recently, a large-scale study of M1 presenting patients, about 30,000 cases. But 40% were 80 or more. And with that comes a lot of comorbidity, and that's a primary presentation. So by the time they fail, they're 85 or more. Do we give them all double therapy, triple therapy?
Yeah, I think this is a really great question. And we also know that the trial populations are not the same as the populations you see in your outpatient clinic. However, there is very good science from ARTA, at least from androgen receptor targeted agents, that, you know, except perhaps for abiraterone, where you need some monitoring and when you need to select out patients that are not, you know, completely cardiovascular wrecks, I think they are very safe. You need to, however, you know, enzalutamide, apalutamide may increase the risk of falls. You have to also add bone protection because you have a higher risk of fractures. So I think if you take the right precautions, you can include quite a lot of elderly and frail patients. And in these studies, they've specifically also looked at age subpopulations, and you see the same results come back. And also, you know, the advantages are also there for the elderly patients. But we all have these patients whom we started on ADT are castrated. They have a fantastic PSA response. PSA goes down to 0, and there are, for years and onwards, they are good with castration alone. And that's the question I asked many times, for instance, also to Gert Attard. I said, Gert, but do we really, why can't we just start with castration, see what happens to PSA response, and then make decisions a little bit later in those frailer elderly patients if the PSA is not going in the right direction, falling down and going to very deep PSA responses less than 0.2, well, then perhaps they need combination, or they may benefit most. And those who do fantastic response, perhaps, I don't know, you may have some time to make decisions, but nobody knows.
So we're on a limited ticket here. So
yeah.
The final question for the last minute or two about biomarkers on the horizon. I mean, we do have some very good biomarkers, and Stephen, you've alluded to PSA drop as a good one.
Yeah.
Bone scans or assessment of tumor burden, another excellent one. Old markers like alkaline phosphatase, lactate dehydrogenase, both extremely good markers. And of course, Gleason grading. Frederica, perhaps the final comment really about where would you put your money? Which marker? I mean, you working in oncology across different specialties will see that in colorectal, in breast, you know, we've got loads of markers, genetic markers and so on. Why don't we have these in prostate?
Yeah, unfortunately, we don't have that. And I don't see anything perfect on the horizon. I think it's more a mixture of different things. Like you said, you have the alkaline phosphatase, you have PSA, obviously, but PSA is getting less and less sensitive when, like, in the history of mCRPC. I think we have the new imaging modalities like PSMA. I hope that we might be a little bit better to analyze the tumor burden, because we're not really good with that with bone scans. So I hope that this will help us to better guide our treatments. And we have like kind of two things right now. We have the intensification side, like you said, with the triple therapy, and we don't really know who are those patients, where do we have to do that. And on the other side, we have those patients where we really try to de-escalate the dose because maybe we're doing too much. So we have to run clinical trials to understand that better. We have clinical trials running right now in France where we try to de-escalate, and we take PSA levels as the marker to try to see when we take Abby off. When can we take the ADT off? Because quality of life is so important for those patients, because they will live a long time now with those treatments. And we all know the toxicity of treatments throughout the years. So I think it's going to be more like a complex, it's not going to be one marker. It's going to be a couple of markers all together who are going to help us, I hope, to guide better our treatments.
Great. So escalation, de-escalation, stratification, and tumor targeting. I think that's a good message to end on. I'd like to thank our speakers for their excellent contributions. I'd like to thank you all for listening. It's a pity we don't have more time. We could talk a lot more about this, but the sun's shining, and well, at least it is here. So enjoy the rest of the evening, and thank you for listening. Bye-bye.
Thank you. Bye.
Bye, everybody. Bye-bye.